So, hello friends. This is the third lecture in the ABG series, and it will cover metabolic alkalosis. So, I'll be starting about the metabolic alkalosis. So, metabolic alkalosis, when we say that patient has a metabolic alkalosis, if there is increase in the bicarbonate or decrease in H plus or both. Increase in bicarbonate, that is more than 26, because normal value of bicarbonate we take at 22 to 26 millimoles per liter. Now, whenever there is we'll just already have explained about the compensation in the metabolic alkalosis, but I'll tell you something about the compensation. Whenever there is a metabolic alkalosis, body has a alkalotic environment. Now, in order to correct this alkalotic environment, body tries to increase CO2, because CO2 is an acidic gas. So how it do increase CO2? By hypoventilating. So body does hypoventilation, that is by decreasing the respiratory rate and decreasing the tidal volume. Now, so CO2 increases. Now, in any metabolic alkalosis, CO2 has to reach a particular value. Only then we will say that this patient has compensated metabolic alkalosis. That is, patient has hypoventilated and CO2 has reached to a point where we will say that the metabolic alkalosis has been taken care of or has been compensated. Now, how to find out that value of PCO2? So for that we have a formula. The value of PCO2 is 40 plus 0.7 into what is the bicarbonate value of that patient, minus 24. If we calculate PCO2 of that patient, and if the PCO2 comes equal to this, that means compensation is adequate. If PCO2 value comes less than this, that means patient also has respiratory alkalosis. If value comes greater than it, that means patient also has respiratory acidosis. So again, in a patient of metabolic alkalosis, patient will try to hypoventilate and increase the CO2 to counteract the alkalotic environment. For that, we have a formula from where we can calculate what should be the value of PCO2. The formula is 40 plus 0.7 into bicarbonate minus 24. If the CO2 of the patient is equal to this, that means patient has a compensated metabolic alkalosis. If the value is less than that, that means patient has also has a respiratory alkalosis. And if the PCO2 is more than this, then means patient also has a respiratory acidosis. So this is a simple. Now, if I ask you a simple question, which of the following four alkalosis or acidosis, that is metabolic acidosis, metabolic alkalosis, respiratory acidosis, alkalosis, has a very poor compensation? So answer will be metabolic alkalosis. Metabolic alkalosis has a very poor compensation. Why? We will understand this. Now we know that PaO2 means alveolar oxygen pressure. Alveolar oxygen pressure. Alveolar oxygen pressure formula is FiO2 into pressure atmospheric minus pressure of water, which we take as 47, and on a normal atmospheric pressure is 760, minus PaCO2 upon RQ, which is known as respiratory quotient. Now, understand this formula. If a patient has a metabolic alkalosis, what he or she will do, he will try to increase CO2 by hypoventilation. And if there is an increase in CO2 value, there will be decrease in the alveolar partial pressure by this formula. A decrease in PaCO2 or increase in PaCO2 will lead to decrease in the alveolar oxygen pressure. And when alveolar oxygen pressure will increase, there will be increase in the body mechanism to hyperventilate. Now, there are two opposite situations which are created. One, in response to metabolic alkalosis, body is hypoventilating to increase the PaCO2, but this increased PaCO2 is causing a decrease in alveolar oxygen pressure, which is causing body to hyperventilate, to increase the alveolar oxygen pressure. Because of this reason, since hypoventilation is being counteracted by the hyperventilation, there is a very poor metabolic alkalosis compensation, and we see a very poor compensation in case of metabolic alkalosis. Now, so once understanding this, we will come to the we'll note the causes. What are the causes of metabolic alkalosis? The first cause that we'll see is the hypokalemia. Hypokalemia. Anything which is causing hypokalemia will cause metabolic alkalosis. Why? For example, if this is the blood stream, this is the cell, and patient has hypokalemia, so body will, since we know outside the cell, that is in the blood, potassium concentration is 3.5 to 5.5 milliequivalents per liter, and inside the cell potassium concentration is 150 milliequivalents per liter. So intracellular potassium is very high, because we know that potassium is cardiotoxic, so its extracellular concentration is low, but its intracellular concentration is very high. Okay. Now, so whenever there is hypokalemia, what happens, that cell gives potassium from the cell to the extravascular space, and in order to maintain neutrality, H plus is taken inside, and when H plus decreases, we know that what we call it, we call it as a metabolic alkalosis. Therefore, the cause of metabolic alkalosis in hypokalemia is intracellular shift of the H plus. So all those causes, all those things which causes hypokalemia, like salbutamol, we all know that it causes hypothermia, then insulin, then lactulose use, and other condition which causes hypokalemia can lead to the metabolic alkalosis. Okay, this is the first cause of the metabolic alkalosis. So whenever you have a metabolic alkalosis, just try to see if potassium is low or not, because if it is low, that can precipitate metabolic alkalosis. Second cause. The second cause is GIT loss, and example is vomiting or excessive suctioning, which we see in ICU patient, or fistula like gastrocutaneous fistulas, or there is a special condition, that is chloride secreting diarrhea. So we have to understand what is the mechanism. Now, in GIT, if this is your stomach, we have a H plus, K plus ATPase, which secretes H plus inside the lumen and K plus inside the cell. This is a parietal cell, also known as oxyntic cell, which we know secretes HCl. So it secretes H plus and takes K plus in. So whenever there is vomiting or excessive suctioning, this H plus containing fluid, and this H plus in the lumen gets combined with Cl to form HCl. We know this HCl is very much important for protein digestion, and this HCl is actually secreted by parietal cell or the oxyntic cell. Now whenever there is too much vomiting, suctioning or gastrocutaneous fistula, this HCl is lost from the body. So there is decreased H plus, decreased Cl minus and fluid loss. So we have a decreased H plus, decreased Cl minus, decreased fluid loss. Also, when there is a decreased H plus from the body, there is a relative increase in bicarbonate. Now, when this bicarbonate comes to the lumen of kidney, in kidney nephrons when this bicarbonate, because of this negative charge, is it's pull potassium into the lumen, and there is also loss of the potassium. So we have a hypokalemia. So this is the condition. We have a decreased H plus, decreased chloride minus, fluid loss, relative increase in the bicarbonate. So this relative increase in the bicarbonate and this loss of potassium causes metabolic alkalosis. Secondly, there is also fluid loss, due to which we have a dehydration. This chloride loss, we have hypochloremia, and this potassium loss, we have hypokalemia. Therefore, whenever there is a fluid loss whenever there's vomiting, suctioning or gastrocutaneous fistula, what we have to give? We have to replenish the fluid loss in the form of normal saline. So it will replenish the chloride, it will replenish the fluid. Also, we have to supplement potassium in the form of the potassium chloride. So this is very important, that why suctioning, vomiting causes metabolic alkalosis along with the chloride loss, along with the potassium loss. So again, I am telling it very fastly, that whenever there is a vomiting or there is a excessive suctioning or gastrocutaneous fistula, there is HCl loss plus fluid loss. This HCl loss and fluid loss lead to this H plus loss leads to metabolic alkalosis. This chloride loss leads to hypochloremia, and this fluid loss leads to dehydration. So there is a relative increase in bicarbonate ion which causes metabolic alkalosis, and when this bicarbonate passes through the lumen, because it is negatively charged, it takes potassium along with it and it causes hypokalemia. And as we have already seen that hypokalemia causes metabolic alkalosis, so there are three reasons why we have metabolic alkalosis. First is the loss of H plus, relative increase in bicarbonate, and hypokalemia. So for treatment of this, we will give normal saline to replenish the chloride and the fluid, and to replenish the potassium, we will give potassium chloride. Now after this, we have seen that there is a fluid loss. So because of the fluid loss, there is dehydration, and whenever there is a dehydration, we know that there is activation of the RAS, and when RAS is activated, the final product is aldosterone. Now this is very important point, because it will be this concept that I am going to tell you is utilized in a lot of places at the medicine. Now, so we will see this is the late DCT, that is distal curvature tubule, or early CT, that is collecting tubule. If this is the lumen and this is the cell, what we see here, we have a very important channel whose name is ENAC, that is epithelial sodium channel. Aldosterone acts on it and increases sodium absorption, and at this area there is a sodium potassium ATPase which secretes 3Na plus outside and 2K plus inside. And here we have ROMK, that is renal outer medullary potassium channel. Renal outer medullary potassium channel. This potassium is secreted into the lumen of the nephron, and magnesium keeps a negative check on this channel. So if there is a low magnesium, this negative inhibitory effect on potassium secretion is lost, and more potassium is lost, and there is a refractory hypokalemia. Therefore, whenever there is a decreased magnesium, we have a refractory hypokalemia. So now, this is one of the cell of the late DCT, early CT. Then there is other cell which is known as apical cell. What it does? It takes H2O plus CO2 and form H2CO3, which breaks into H plus and HCO3 minus. This H3O minus is directly absorbed into the blood, and there is a ATPase, H plus ATPase, which secretes this H plus into the lumen. So now from now onwards, always remember, whenever there will be increased aldosterone, there will be more sodium absorption, and when more sodium will be absorbed, more sodium will be secreted outside, and more potassium will be secreted inside, and thus more potassium will be lost through the ROMK channel. So whenever there will be more aldosterone, there will be increased sodium absorption and increased potassium excretion. This will be always be there, that there will be increased sodium absorption and increased potassium secretion. Also, increased aldosterone will lead to more H plus secretion into the lumen. So there will be increased H plus excretion also. And there will be more bicarbonate absorption. So there will be more bicarbonate absorption. These four things we will see whenever there will be more aldosterone. First, there will be more sodium absorption, and thus there will be more activity of the sodium potassium ATPase. So there will be more potassium which will be secreted through ROMK, and so we have increased sodium absorption, increased potassium excretion leading to hypokalemia, and there will be increased H plus excretion through H plus ATPase. So we have more H plus excretion, and we have a more bicarbonate absorption into the blood. Now understand, this bicarbonate is also absorbed from the proximal converted tubule, but since that is the bicarbonate which is that bicarbonate is the filtered bicarbonate which is absorbed, but here this bicarbonate is coming from H2 and CO2. So this absorption of bicarbonate in the late DCT and early CT is known as de novo absorption of the bicarbonate. So aldosterone also increases the de novo absorption of the bicarbonate. So we are seeing that these four things happens whenever there is aldosterone, that is increased sodium absorption, increased potassium excretion leading to hypokalemia, increased H plus excretion, and these two things will lead to metabolic alkalosis. So whenever there will be, from now you remember just these things, that whenever there will be increased aldosterone, there will be metabolic alkalosis because of increased H plus excretion and increased bicarbonate absorption, and there will be hypokalemia. So I am writing, whenever there will be increased aldosterone, there will be hypokalemia and there will be metabolic alkalosis because of increased H plus excretion and increased bicarbonate absorption. You have to remember this point. Now we have seen that vomiting, suctioning, gastrocutaneous fistulas manifestation. Now whenever there will be increased vomiting, suctioning, what will happen? There will be dehydration, there will be RAS activation, and increased aldosterone. So what it will do? It will lead to the what? It will lead to hypokalemia and metabolic alkalosis by H plus excretion and increased de novo bicarbonate absorption. So in the first stage, this GI loss, that is vomiting, suctioning or gastrocutaneous fistula, causes metabolic alkalosis, and then in the second stage, when there is RAS activated, it again causes hypokalemia and metabolic alkalosis. So treatment of this condition will be giving of the normal saline to replenish the chloride and the fluid, and second is replenish the potassium in the form of potassium chloride. And we have known one fact, that whenever we see that there will be aldosterone, I have told you, there will be hypokalemia and there will be metabolic alkalosis due to increased H plus excretion and increased de novo bicarbonate absorption. So now third cause. So these were the causes of GIT, causes of the metabolic alkalosis. Now third cause will be diuretic use. Now every diuretic causes alkalosis. Every diuretic causes alkalosis. The only diuretic that causes acidosis is acetazolamide. It is acetazolamide, because acetazolamide inhibits the carbonic anhydrase in the lumen as well as in the cell. Therefore it decreases proximal PCT, that is proximal converted tubule bicarbonate absorption. So it causes acidosis, and rest of the diuretic causes alkalosis. For example, we have two types of diuretic. One is the loop diuretic, which acts on the thick ascending loop of Henle, and then we have a thiazide diuretic, which acts in the early part of the DCT. If you want to know on which channel this loop diuretic act, it blocks the sodium chloride, 2-chloride and potassium channel. So this sodium chloride and potassium absorption is hindered, and this thiazide block sodium chloride channel. So when loop diuretics act on the thick ascending limb of LA, there will be decreased sodium and decreased sodium absorption, decreased chloride absorption, and decreased potassium absorption. And when thiazide will act on the early DCT, there will be decreased sodium and chloride absorption. So now what will happen? More and more sodium will reach to the distal part of the distal convoluted tubule or the early part of the collecting tubule. So try to understand. I have already told you that in late part of the DCT or early part of the collecting tubule, I have already explained you what happens. So when more and more sodium will be reaching to the late part of the DCT or early part of the collecting tubule, more sodium will absorb, and thus there will be increased activity of the 3Na plus sodium potassium ATPase. So more potassium will be coming inside the cell and more potassium will be lost. And there will be increased H plus excretion to the lumen and increased de novo bicarbonate absorption. So this will lead to what? It will cause the same effect as there was due to the RAS activation. But here this is known as secondary hyperaldosteronism. So what diuretic will cause? Diuretic will, like loop diuretic or thiazide diuretic, will increase the sodium load in the late DCT or early CT, where more sodium is absorbed and more potassium is secreted. So it will cause hypokalemia. Secondly, more H plus will be secreted, so it will cause metabolic alkalosis. There will be increased bicarbonate absorption, so it will cause it will lead to metabolic alkalosis. So these things happen. Thus, this is the reason why they cause metabolic alkalosis. I hope it is clear. It is just like the hyperaldosteronism due to RAS activation. So this is the diuretic. So diuretic cause. Fourth cause. Fourth cause is magnesium. We know that whenever we have a decreased magnesium, we have a decreased hypokalemia, decreased potassium, and decreased potassium causes metabolic alkalosis. Fifth cause, penicillin group of drug. Now penicillin group of drugs, they causes metabolic alkalosis. How? They increases the non-absorbable anion. So when this non-absorbed anion increases, it pulls H plus along with it into the lumen, and there is a more secretion of H plus, leading to metabolic alkalosis. So these are the causes. Now coming to the sixth cause, we have seen that any cause that will increase aldosterone will lead to the excretion of lead to more excretion of potassium, lead to more excretion of the hydrogen, increase absorption of bicarbonate, so it will lead to metabolic alkalosis. So now anything that is causes hyperaldosteronism will also lead to metabolic alkalosis. Now we know that in RAS the starting product is renin and end product which is formed is aldosterone. We know that renin converts the angiotensinogen secreted from the liver into angiotensin 1, and then this angiotensin 1 goes to the lungs, where it is converted by ACE enzyme into angiotensin 2, which leads to the increased aldosterone. So anything which will increase the renin or will increase the aldosterone will cause the metabolic alkalosis, as I have already explained to you. So what are the causes of increased renin? We have to remember 4 important causes. One is the renal artery stenosis. Renal artery stenosis increases the renin. This is generally seen in young patient. In young patient, renal artery stenosis will present as, in young patient, if there is hypertension, and then we suspect renal artery stenosis, because most common cause of malignant hypertension in young patient is renal artery stenosis. Then in old patient, because of renal artery atherosclerosis, that is atherosclerotic plaque, then estrogen therapy has seen. Therefore, in Harrison, in the table, it is mentioned that estrogen therapy can cause metabolic alkalosis. So how it causes? Estrogen therapy increases renin, renin increases aldosterone, and when aldosterone is increased, it will lead to metabolic alkalosis and hypokalemia. And fourth is renin secreting tumors. So in all these things, there will be hypokalemia and metabolic alkalosis. And how will you diagnose? In these patients, we have increased renin and increased aldosterone. Okay. In this condition, where there will be increase in the aldosterone, there will be decreased renin and increased aldosterone. And this can be because of the adrenal adenoma, adrenal hyperplasia, then congenital adrenal hyperplasia, and really due to adrenal cancer. So all these conditions you will have lead to metabolic alkalosis. In these four conditions, there will be increased renin, increased aldosterone, and in these four conditions, there will be decreased renin and increased aldosterone. Now, after these 7th point, now anything that will cause Cushing syndrome will also cause metabolic alkalosis. Now this is very important to discuss, because a lot of time patients just have hypertension and hypokalemia and metabolic alkalosis. So we have to understand how to diagnose these patients. So first we have to understand little bit about Cushing syndrome. What will happen in Cushing syndrome? We have just like hyperaldosterone, we have a decreased renin in these patients and increased aldosterone. Basically, Cushing syndrome definition is increase in the level of glucocorticoids leading to symptoms which can be related to glucocorticoid is known as Cushing syndrome. So what is Cushing syndrome? In Cushing syndrome, there is increased glucocorticoids leading to the symptoms which can be related to the increased glucocorticoid level. Also in these patients, you will have some amount of increased aldosterone and decreased renin. So these patients will develop metabolic alkalosis. They will develop because there is increased aldosterone, and I have already explained to you, increased aldosterone will lead to hypokalemia, metabolic alkalosis. So these patient has a hypokalemia, metabolic alkalosis, and since increased aldosterone will lead to increased sodium absorption, there will be increased blood volume, so there will be hypertension. So generally 3 things you will see in patient of Cushing syndrome. The first thing that you see is increased hypokalemia, metabolic alkalosis, and hypertension. Some of the patient of Cushing syndrome will present you just with hypertension and refractory hypokalemia, and you have to make diagnosis that where the cause of this patient is Cushing syndrome and where is the tumor. So now I'll tell you something. First you have to understand the types of Cushing syndrome. Then Cushing syndrome can be basically, we all know that if this is your pituitary gland, this is your hypothalamus, and this is your adrenal gland. So hypothalamus secretes CRH, that is corticotropin releasing hormone, and when this corticotropin releasing hormone is secreted by the paraventricular nucleus of the hypothalamus, it acts on the pituitary gland and it secretes ACTH, and this ACTH acts on the adrenal gland and it secretes cortisol, and increase in the cortisol is known as Cushing syndrome. So basically Cushing syndrome is divided into 2 points, that is ACTH secreting tumor and non-ACTH secreting tumor. ACTH secreting tumor can also be divided into 2 points. One is the pituitary adenoma, which normally secretes pituitary, which normally secretes ACTH, and second is the ectopic ACTH secretion, which can be secreted from the small cell lung carcinoma, from medullary thyroid carcinoma, from carcinoid tumor of bronchus, or from pancreas, and pheochromocytoma. So we know that Cushing syndrome can be divided into 2 parts: ACTH secreting tumor, which can come from the pituitary adenoma, or it can come from the ectopic ACTH, and this can be secreted from a small cell lung carcinoma, medullary thyroid carcinoma, or carcinoid of bronchus, pancreas, and pheochromocytoma. Now this is very important thing we have to understand. What is the difference between Cushing syndrome and Cushing disease? Now, if the increased ACTH is coming from the pituitary adenoma, and if the cause of Cushing syndrome is pituitary adenoma, then this is known as Cushing disease. So all Cushing disease comes in Cushing syndrome, but all Cushing syndrome does not come in Cushing disease. So when Cushing syndrome can be localized, or the cause of Cushing syndrome is said to be the pituitary gland or the pituitary adenoma, then it is known as Cushing disease. Then we come to the non-ACTH secreting tumor, which can be generally from the adrenal gland. So it can be adrenal adenoma, it can be adrenal carcinoma, then it can be because of very important condition, that is primary bilateral adrenal hyperplasia. Primary bilateral macronodular adrenal hyperplasia. Primary bilateral macronodular adrenal hyperplasia, which we'll discuss after some time. So this is about the Cushing syndrome. Now, how will we diagnose Cushing syndrome? For example, if we have a patient with hypertension, hypokalemia, and metabolic alkalosis, so we are suspecting metabolic alkalosis and hypokalemia, and we are suspecting Cushing syndrome. So how will we diagnose? The initial thing that we'll do is we will go for the serum cortisol. Sorry, we'll go for the salivary cortisol midnight. First thing. Second, we'll go for urinary free cortisol value. And third, we'll go for the low dose dexamethasone suppression test. If these things come positive, then we will say that this patient has Cushing disease, Cushing syndrome. Then we will say that this patient has Cushing syndrome. So salivary cortisol, urinary free cortisol, and low dose dexamethasone test. If these things comes positive, then this we say that this patient has a Cushing syndrome. Why? Because there are some condition which mimics like Cushing disease. So those conditions are known as pseudo Cushing syndrome. Those conditions are known as pseudo Cushing syndrome, and examples are obesity, alcohol, and depression. So there are a lot of things which mimics like Cushing syndrome. So we have to differentiate that whether this patient has Cushing or not. So we go for these three things just to screen the patient. So what should be the salivary cortisol value, cutoff value? If it is more than 5 nanomoles per liter or more than 2 times the normal. Urinary free cortisol, it should be more than 2 times the normal value. And low dose dexamethasone. What is low dose dexamethasone test? In low dose dexamethasone test, we give 1 mg of the dexamethasone at 11 p.m. and calculate cortisol at 8 a.m. in the morning. So for understanding dexamethasone test, we have to understand an important point. For example, if this is hypothalamus This is pituitary gland, this is adrenal gland. We know that hypothalamus secretes CRH, this CRH secretes ACTH, which secretes cortisol. Now if we use 1 mg of dexamethasone, that is low dose dexamethasone, so what it does in normal patient, if I'll give a 1 mg dexamethasone in the night and I will measure the cortisol. So since this cortisol gives a negative feedback mechanism to the ACTH and the CRH, so whenever there is increased cortisol, there will be decreased ACTH, decreased CRH, so there will be a decreased cortisol because of the negative feedback mechanism. So whenever I'll give 1 mg dexamethasone to a person, there will be increased cortisol value, and thus there will be a inhibitory effects on this CRH and ACTH, and there will be decreased cortisol secretion. So serum cortisol will decrease. So what is the cutoff value? We take cutoff value to the 50 nanomoles per liter. So in normal patient, the value will come less than 50 nanomoles per liter. But if I give 1 mg of the dexamethasone and the value of the serum cortisol comes to be more than 50 nanomoles per liter, then that means this cortisol, that the patient has a Cushing syndrome, because there is no inhibitory effect is seen. There is no decrease in the cortisol value. You have to understand this point. So low dexamethasone test confirms that this patient is having Cushing syndrome, and if we have given dexamethasone, there is no decrease in the serum cortisol. So when these 3 tests will be positive, we'll say that patient, so in this we'll give 1 mg dexamethasone at 11 p.m. and calculate cortisol at 8 a.m. It will come more than 40 nanomoles per liter. So after doing these 3 tests, we are confirmed that this patient has a Cushing syndrome. Now we have to localize. So for that, we will do ACTH value, and ACTH value, as we have seen that we can divide the Cushing syndrome into ACTH secreting tumor and non-ACTH secreting tumor. So it can be divided into 2 ACTH value. ACTH value can be equal to or more than 15 picogram per ml, or it can be less than or equal to 5 picogram per ml. If it is more than 50 picogram per ml, that means it is an ACTH secreting tumor, high chances. So it can be from the pituitary or it can be from the ectopic source that we will have seen. So we will do again 3 tests. One is the MRI of the pituitary. Other is a high dose dexamethasone suppression test. And third we will do CRH test. Now we have seen that in low dose dexamethasone suppression test, if we give 1 mg of the dexamethasone, in normal patient there will be decreased cortisol below 50, and in Cushing syndrome it will remain above 50 nanomoles per liter. Now what is high dose dexamethasone suppression test? For this you have to understand that from pituitary there is secretion of ACTH. Whenever there is CRH secretion from the hypothalamus, there is increased ACTH secretion from the pituitary, or ACTH can be secreted directly from the pituitary adenoma without CRH stimulation. There are 2 ways by which ACTH can be secreted from the pituitary, either by the CRH stimulation or by the pituitary adenoma, which by itself can secrete the ACTH. So whenever the ACTH is being secreted by the pituitary adenoma, please remember this, whenever the ACTH is being secreted by the pituitary adenoma, it follows CRH, it follows all the regulatory mechanism. I will explain what this means. This means that if a patient has a pituitary adenoma and it is secreting ACTH, and if I will give CRH to the patient, there will be increased ACTH secretion and thus there will be increased cortisol. But it will not be seen in cases of the ectopic ACTH secreting. For example, if the ACTH is being secreted from the small cell carcinoma or pheochromocytoma, or from the carcinoid tumor of the pancreas, or from the bronchial carcinoid, this thing will not be seen. That if we'll give CRH, there will be no increase in the ACTH and no increase in the cortisol. But if the ACTH is being secreted from the pituitary, there will be increase in the ACTH value and cortisol value. So this CRH test can help us to differentiate the pituitary adenoma secreting ACTH from the other ectopic ACTH. So this is one thing. Second thing, if we'll give a high dose dexamethasone, like that is 8 mg of dexamethasone or 2 mg 6 hourly, 2 days for 2 days, we'll give that, then what will happen? This dexamethasone will suppress the ACTH value and thus will suppress the cortisol value in case this ACTH is being secreted from the pituitary adenoma. But high dose dexamethasone will not suppress the ACTH secretion if it is secreted from the ectopic tumors. Okay, so this is very important thing. So what we'll do, we will do MRI of the pituitary, and if MRI comes positive, that is pituitary adenoma is diagnosed, then we'll go for the FES surgery, that is functional endoscopic sinus surgery, and that we do transesophageal through transesophageal route. Then we'll do high dose dexamethasone test and CRH test. How do we do high dose dexamethasone test? We give 2 mg of dexamethasone 6 hourly for 2 days. And then we measure the serum cortisol. How we do CRH? We give 100 microgram of CRH and then we measure ACTH and cortisol. So I have told you, when we'll say that CRH, in cases of pituitary adenoma, whenever we will give CRH, there will be increase in the ACTH and increase in the cortisol. When we will say that this CRH is positive, whereas in case of ectopic ACTH secretion, CRH test will not be positive. So when we will say that CRH test is positive, if after giving of 100 microgram of CRH, ACTH increases by 40% from the baseline within 15 to 30 minutes, or there is increase of cortisol about 20% from baseline after 45 to 60 minutes. This is mentioned in the Harrison 21st edition. So then we will say that this is CRH positive, and CRH positive means that this ACTH is coming from the pituitary and not from the ectopic ACTH gland. When we will say high dose dexamethasone test, if we'll give this amount of dexamethasone and we measure serum cortisol, and serum cortisol decreases by 50% of the baseline, then we say that this is positive, and positive means that ACTH is being secreted from the pituitary and not from the ectopic. So if these two tests come positive, that means patient is having pituitary adenoma and we again go for the surgery. Because in 40% of the cases, MRI misses the pituitary adenoma. What Harrison say, in pituitary cases, 40% of the cases, MRI is not able to diagnose this pituitary adenoma. So if this two high dose dexamethasone suppression test and CRH test comes positive, then that means that there is a pituitary adenoma, and if it comes equivocal, that means one comes positive, other comes negative, or both are not able to meet their criteria, that means we are still thinking of Cushing disease, we are thinking of pituitary adenoma. So what we will do, we will calculate the what is called as inferior petrosal sinus blood, and we will calculate the ACTH value in this sinus blood and the serum blood. If the value is more than 2, then it is the most confirmatory test of the Cushing disease, that is this ACTH increase is coming from the pituitary. Then again we will go for the surgery. So this is known as inferior petrosal sinus blood collection, and if the value is more than 2, that means patient has pituitary adenoma. If both the test come, that is high dose dexamethasone suppression test and CRH test, both comes negative, then we have to think in terms of ectopic ACTH secretion, and we have to diagnose these things. As we have already seen, ectopic ACTH, the cause is small cell lung carcinoma, medullary thyroid carcinoma, carcinoma of the bronchus or the pancreas, and pheochromocytoma. So this we have seen that if the ACTH value is more than 15 picogram, then what will, if the value is less than 15 picogram per ml, then what we'll do, if the ACTH value is less than 5 picogram per ml, then we will think that the cause is most probably the adrenal adenoma or adrenal carcinoma or primary bilateral macronodular adrenal hyperplasia. So in adrenal adenoma, in this we will go for unilateral adrenalectomy, and in primary bilateral macronodular adrenal hyperplasia we will go for the bilateral adrenalectomy. So these were the causes of the metabolic alkalosis, and along with the causes of the metabolic alkalosis, we have seen what is the treatment of the metabolic alkalosis. Now in one and or two more lectures, ABG will be finished.